అది వచ్చిందా సత్యన్ అది? I think Vijay can start, Vijay.
Yes, sir. Okay, sir. Namaskara.
Vijay.
Yeah.
I'm not seeing much of participants. Shall we wait for a few minutes? Because I'm not seeing much of participants. What would you say?
No, here I think only those who are in the room, only those participants I think we may get here.
Okay. Right. Right. Because otherwise we don't get the other participants.
Satya.
Yeah.
Namaskara. Greetings from Hubli, Dharwad. Myself, Dr. Vijay Kamath, President of ASI Hubli Dharwad City Chapter, welcome you all for today's webinar from Asian Institute of Gastroenterology. Our speaker, Dr. G.V. Rao, whom all of you know, and he doesn't require any introduction. He is going to speak on World of Pancreatic Necrosis, that is WOPN, interventions in 2020. The chairpersons are Dr. B.R. Patil from Hubli, oncosurgeon from Hubli, Dr. Sadasivaya Sopinmat, our President, Karnataka State ASI and a gastrointestinal surgeon, Dr. Srinivas Pai, Professor and Head of the Department, SDM Medical College, Dharwad. Now, I hand over the mic to Dr. G.V. Rao to start with his lecture on World of Pancreatic Necrosis.
Thank you so much. At the outset, I am humbled by this invitation from the ASI Hubli Dharwad City Branch. My sincere thanks to the entire executive of the ASI Hubli and Dharwad for this kind invitation. My sincere thanks to Dr. Srinivas Pai, Dr. Sopimat, Dr. B.R. Patil, Dr. Vijay Kamath and Dr. Mulki Patil, who all been my friends actually through the years. They have been with us, and I'm very, very humbled by this invitation. I'm sure as we go through the thing, I would like to share what are the interventions that we do in acute pancreatitis or walled up pancreatic necrosis as in today in 2020. I'm sure these are the experiences with most of the people who are watching this, including the chairpersons, are very active surgeons who are involved in management of acute pancreatitis. And it is not only my view, but I would like to listen to the other perspectives of the senior surgeons like B.R. Patil, Dr. Sopimat, Dr. Srinivas Pai, Dr. Vijay Kamath, and maybe we can just give very clear messages as to what has to be done in acute pancreatitis and walled up pancreatic necrosis in 2020. Thank you once again, Vijay, for taking all these efforts. Thank you, Sopi. Thank you, Dr. B.R. Patil and Dr. Srinivas Pai. Now, a brief background of acute pancreatitis. Now, we all know that it is one of the most commonest admissions to the intensive care and the critical care and is associated with significant morbidity and mortality. Most of the literature is focused on drainage and debridement techniques and technology with improved morbidity and mortality. Surprisingly, there seems to be some disconnect between the critical care specialties who are responsible for the continued morbidity and mortality. It is not only the drainage and debridement, the critical care is also involved in the management of these patients with acute pancreatitis. So, a beautiful article which was come up in 2020s very recently about 8 fundamental steps revised according to the pancreas acronym. Actually, it's very good acronym for undergraduates and postgraduates in general surgery as to what are the 8 fundamental steps that we take in severe acute pancreatitis. Now, P stands for perfusion, A stands for analgesia, N stands for nutrition, C stands for clinical examination, R stands for cross-sectional imaging or radiological imaging, E stands for ERCP, and A stands for antibiotics, and S stands for surgery, interventional radiology or endoscopic interventions that we do in these patients. So basically, in addition to this, the critical care is very, very important in these patients. So critical care is what is very important during this initial phases of severe acute pancreatitis, and all these 8 fundamental steps needs to be followed. A brief review of what we do in severe acute pancreatitis. The perfusion goal in these patients with severe acute pancreatitis is to reach a CVP of 12 to 15 millimeters of mercury and a urinary output of 0.5 to 1 ml per kg per hour and an IVCP collapse index of more than 48%. This is the goal, this is the perfusion goal. Whatever solution that we are using, ring lactate solution that we commonly use, the idea is to achieve this perfusion goal. The second, analgesia. Now, this analgesia in severe acute pancreatitis is basically multimodal, systemic, combined pharmacological agent, and sometimes it is combined with an epidural block. N stands for nutrition. The precocity, enteral feeding in gastric or post-pyloric position. Parenteral nutrition works best in difficult cases to achieve the individual total caloric values. So as far as possible, we treat this patient on enteral nutrition, but parenteral nutrition is standby for these patients. Clinical examination, the classified as mild, moderate and severe pancreatitis according to Atlanta criteria. Cross-sectional imaging, it is best that we do the CT on the 4th day for prognosis or to modify the management in these patients. E stands for ERCP, it's indicated in cholangitis, unpredicted clinical course and ascending jaundice in these patients. A for antibiotics, only rational indication in documented acute pancreatic infections. You should not use antibiotics irrationally. Surgery, interventional radiology or endoscopy. The dogma is represented by 3 Ds, delay, drain and debride. The preferred method is minimally invasive step-up approach in 2020, which allows for gradual or more invasive procedures when the previous treatment fails. Now, this is the contemporary therapeutic strategy which is summarized in 5 Ds. You delay the treatment as much as possible, you drain the infected pancreatic fluid, debride as much as possible, but if you deviate from any of these norms, obviously we end up with high mortality in these patients. So we have to stick to this delay, drain, debride concept, and if you deviate from this, we'll be ending up with high mortality in these patients. So if you look at acute pancreatitis, now we have interstitial edematous pancreatitis. In less than 4 weeks, it is acute peripancreatic fluid collections. More than 4 weeks, it ends up with a pseudocyst, and it is a necrotizing acute pancreatitis. Less than 4 weeks, we call it as an acute necrotic collection, and more than 4 weeks, it is called as walled-off necrosis or walled-off pancreatic necrosis. This is the standard classification of how you deal with these patients with acute pancreatitis. So if you look at the evolution of peripancreatic fluid collections, you can see this. Basically, we have interstitial type and necrotizing type, and interstitial type ends up with wherever there is a breach in the pancreatic duct, this ends up with a pseudocyst, and whenever there is necrosis, usually we end up with pancreatic necrosis, and after 4 weeks, these usually are called as walled-off necrosis or walled-off pancreatic necrosis. Now, Todd Barron, an endoscopist, he is the one who created this term called WOPN or walled-off necrosis. Basically, it's an endoscopic definition. I call this an endoscopic definition. Basically, it has been tailored to suit the needs of endoscopists and to suit the needs of endoscopic intervention. So basically, what it means is, on cross-sectional imaging, if you're seeing only fluid, it is called as pseudocyst, and even small amount of debris that you see, it is called as walled-off pancreatic necrosis. So in 2020, endoscopic interventions are endoscopic ultrasound based, and endoscopic ultrasound is very highly sensitive to pick up debris. So what happens is the conversion rate is very high. So all the CT pseudocysts that we report on CT become endosono wands, because endoscopic ultrasound picks up small amount of debris, and as per definition of wand, even small amount of debris in the fluid collection, it becomes a walled-off necrosis. So most of the wands in endotherapy series are CT pseudocysts. So by definition, they could be wand because basically based on endoscopic ultrasound, but basically they are maybe pseudocysts. Now, are they no non-wands? What I'm saying is, you're talking about walled-off necrosis. What do you call about this extensions? See, whenever we have this with restricted to the peripancreatic area, in close approximation to the stomach or duodenum, is called as walled-off pancreatic necrosis. But what happens to these collections when they extend into paracolic gutters, when they extend into the mesentery pelvis, and when extend into the mediastinum? Now, this is the terminology pancreatic necrosis completely obsolete in 2020? No, absolutely. Now, these are called as extended walled-off pancreatic necrosis. What walled-off pancreatic necrosis is basically collections which are in good abutment to the stomach or duodenum. That's an endoscopic definition, and all those which extend beyond are called as extended walled-off pancreatic necrosis. So all the management concepts of peripancreatic fluid collections have evolved from surgery. There is absolutely no doubt about this. Now, surgery has been the gold standard for management of peripancreatic fluid collections from time immemorial. World across, surgery was the gold standard. Now, whenever we have this infected pancreatic necrosis, suppose infected pancreatic, the mortality is about 30% in these patients, and whenever we have septic complications, the mortality increases to 80%. And if the patient is associated with multi-organ failure and you continue to treat this patient conservatively, it's almost 100% mortality in these patients. The timing of intervention is very, very important. There is a beautiful trial which has shown that whenever we intervene in this patient less than 2 weeks, the mortality is almost in the tune of 65%. Now, this trial shows that when we do early versus late, the mortality is 56% versus 27%. So the carry-home message is that we delay the intervention. Early intervention is associated with significant morbidity and mortality, and this delaying of intervention is basically beyond 4 weeks. This is basically for a proper demarcation of peripancreatic and pancreatic necrosis. It decreases the risk of bleeding, and it minimizes surgical related loss of vital tissue whenever we intervene after 4 weeks. So the therapeutic approach of infected pancreatic necrosis is drain the infected fluid as much as possible and mechanical removal of as much of necrotic tissue as possible. This is one such thing which shows that entire necrosum has been removed surgically. Now, is there any indication for intervention in sterile necrosis? Sterile necrosis without organ failure, absolutely it is conservative, non-surgical, medical management. Now, sterile necrosis with organ failure, now these patients have poor outcome both surgically and with conservative treatment, and in select cases surgery may be indicated, but again this is associated with increased morbidity and mortality. Now, what are the indications for intervention in walled-off pancreatic necrosis? Infection, organ failure, intractable pain, gastric outlet obstruction, or a disconnect duct are all the indications for intervention. And as I told you, surgery has been the gold standard world over, but in 2010, Panther Trial came in a big way. The interventional radiologists put in a pigtail catheter and subsequently did a minimally invasive surgery, and they said this is the best way to treat this patient. Now, this is a very small series. You can see this. This is the paper that got published in NEJM, a very high impact journal. You put in a pigtail catheter, drain the infected fluid, and the patient improves, it's okay. If the patient does not improve, we make a small incision and then debride, and open surgical debridement is done with a small incision. Now, this Panther trial had taken across the globe. This is the very small series of patients that was published, very, very small series. and they've also published their long-term follow-up in 2019 saying that it's a step-up approach is superior. But there are a lot of limitations of this Panther trial which have been done. I will show you the limitations of this Panther trial, but this one trial has changed the entire concept how we manage. So from 2010, people have switched over to this step-up approach from the initial surgical management, and we started putting in pigtail catheters and started doing minimally invasive interventions for these patients. Now endoscopic, now this beautiful analysis that came in, actually this is a trial that shows that both endoscopy and surgery are preferable over percutaneous interventions. Furthermore, endoscopy associated with lesser interventions than surgery, because surgery came in a big way, endoscopy came in a big way, and this IR, the Panther, created tension among endoscopists, and what happened was lot of endoscopists across the globe started improving their endoscopic technologies to drain this walled-off pancreatic necrosis. So from intervention radiological procedure putting in a pigtail, endoscopists started doing endoscopic interventions for this, and as in today, if you have walled-off pancreatic necrosis, it is either interventional radiology, endoscopy or surgery, and surgery could be open, laparoscopy or retroperitoneal scope. Let us see all these modalities. In our department, we have all these three modalities which are available, and as I will tell you subsequently that any patient that comes to the our hospital usually goes to the pancreas board, and we decide which type of intervention this patient has to undergo. So let us look at the endoscopic interventions. This is the endoscopic intervention that came in. People started draining this. You make a hole in the stomach and the posterior wall, dilate this with a balloon dilator, and subsequently debride this, and subsequently put in a plastic stent. This is what is called as some sort of a direct endoscopic necrosectomy. But surprisingly, if you see, it is associated with significant mortality and complications like bleed, perforation, infection and air embolism were seen with this. And sometimes we see these stents which are migrated because the walled-off necrosis is not completely approximated with this, and these patients come back to surgery for intervention because of massive pneumoperitoneum and leakage of this fluid into the peritoneal cavity. Now to overcome this, short biflange self-expandable metallic stents have come. These are called lumen opposing metallic stents. These have come into clinical practice, and they have changed the entire way in which this endoscopic drainage is being done. And these fully covered stents, metallic stents, have been shown to superior to the fully covered stems that and the plastic stent that have been used in endoscopic practice so far. So initially we used to use plastic stents or fully covered stems. Now these have been replaced completely with lumen opposing metallic stents, and you see data from across the world, including our own data, which shows that these peripancreatic fluid collections can be very effectively drained using this lumen opposing metallic stents. And if you see the comparative outcomes of endoscopic ultrasound guided cystogastrostomy for peripancreatic fluid collection, a beautiful meta-analysis, we found the technical success or adverse rates of drainage based on peripancreatic fluid corrections or the stent type. And if you can see this lumen opposing stents seem to have taken the world by a big stride. Now, how do these endoscopic interventions compare? The initial endoscopic interventions always compared with open necrosectomy. Now, if you see all these randomized trials which came in, endoscopic procedures were purely transgastric. So all these localized collections in good approximation to the stomach or duodenum were compared to open surgical necrosectomy, and they said, of course, the endoscopic approach is better, basically because of the pancreatic fistula rate is higher, and these had required multiple interventions. Obviously, because you're not including all patients in this, and if you see this clinical endpoint, they said endoscopic interventions are slightly better than surgical interventions. Now we have this other trial, the tension trial, which came in again showed that endoscopic or surgical step-up approach. Now this is the trial that compared the endoscopic drainage with the Panther type of intervention, surgical step-up approach, initial drainage followed by step-up approach. And here also you see that the fistula rate is slightly higher on surgical side, and also the hospital stay is slightly longer. Obviously, again, because you're including all types of peripancreatic fluid collections in surgical group, vis-a-vis only localized collections in endoscopic group. With all these interventions that have happened on the endoscopic side, endoscopists started believing that it is time to change the of God, and minimally invasive endoscopic interventions will be the gold standard in the management of peripancreatic fluid collections. This is a myth. I can understand that we all understand for localized peripancreatic fluid collections in good approximation to the stomach and duodenum, this can be dealt with endoscopically, but not all patients can be dealt with endoscopically. Now, there is a myth among endoscopists that this gastric juice that gets into the retroperitoneal cavity aids in clearance of the necrosum, and we all know that the instrumentation that is available on the endoscopic side has lot of limitations. The stent that we use, the Roth basket, or even the forceps that is used to extract the necrosum, we know how difficult it is to remove the necrosum. We use a blunt finger to do the necrosectomy. Sometimes we use a sponge holder to do this, and even with this, the necrosectomy may not be complete. So endoscopy has limitations as to the amount of endoscopic necrosectomy that can be done, basically because of the limitation of equipment. Now, even I'll show you our own data from our own department. What it shows is we have done all these patients with peripancreatic fluid collections, and you can see this. We have taken patients who are taken for endoscopic drainage. These are the patients who came for endoscopic drainage. This is a publication from our department, and if you see this, majority of these patients did not have any symptoms, any problem other than putting in a plastic stent. You can see this, majority, almost 1/3 or 2/3 of the patient did very well with just putting in a metallic stent or a plastic stent, and almost 75% of these patients did very well. Now, of these rest of the patients who did not do well, these are the patients who underwent a re-intervention in the form of declogging. I'll show you what declogging means, or they underwent a nasocystic insertion, or some patients underwent direct endoscopic necrosectomy. So, I hope I am very clear. Majority of the patient, 2/3 of the patient, just putting in the stent, the entire fluid was drained, and whatever minimal debris was there, that was drained. Basically, again, because these walled-off necrosis had very minimal amount of debris and they did not require any debridement. Only very small percentage, you can see this, very small percentage of these patients require direct endoscopic necrosectomy in this patient. When I mean declogging, I mean you put in a stent, these patients do well. Suppose this necrosum gets blocked, you just remove this necrosum that is blocked the stent, and these patients do well. And suppose the patients continue to have this problem, we put in this nasocystic drain, and or sometimes we do this direct endoscopic necrosectomy using this the snare or a Dormia basket or a Roth basket. And if you see our own data that is published, majority of them do very well. A very small percentage of these patients require direct endoscopic necrosectomy. And because endoscopic necrosectomy cannot be done completely, they have started combining endoscopic transgastric drainage along with the percutaneous drainage. So, here is one such patient who has undergone endoscopic drainage and also a percutaneous drainage for extended walled-off pancreatic necrosis. So, these patients had a combined technique. So, when we do this combined technique, we drain as much of fluid as endoscopically, and we put this pigtail catheter, and subsequently you dilate this tract using a balloon dilator, and using a flexible scope we go into this walled-off necrosis and do as much necrosectomy as possible. So, you can see this is how a combined endoscopic and a percutaneous approach is done to do this debridement in these patients with walled-off necrosis. So, we have this interventional radiology procedure, that is a Panther trial, which says a step and percutaneous and a step-up approach, which is best. Actually, most of the centers have switched to this, and we have this endoscopic techniques that have come in, the Penguin trial, the tension trial, the Nagy stent and the Axio stent, which are very popular. Now, The question that is asked repeatedly is this: are these Panther trial, the Penguin trial, the Tension trial, the Nagi and the Axios stent that are available right now death knell to surgery? Does it mean that we don't have any role for surgery as in today? What happens to all these extended pancreatic necrosis? Not all of them can be dealt with endoscopically or radiologically, and we have surgery which is still the gold standard, and as I told you, all the management concepts seem to have evolved from surgery and surgery alone. We have been doing this open necrosectomy. As this video shows, we used a blunt finger to take out this necrosum, and we used this sponge holder to take out the necrosis. In spite of this, we had very good results, though it's associated with significant, some amount of morbidity and mortality, but you are able to achieve complete necrosum. And at the end of the procedure, we usually do a closed continuous lavage or planned laparotomy with delayed closure, or open packing with relaparotomy. The common procedure that is done is a closed continuous lavage, wherein after doing this necrosectomy, we put these two drains to which irrigation is continued till the debris is cleared, and we have the amylase content of this fluid is very, very low. And whenever we have this walled-off pancreatic necrosis with certain amount of colonic communication, this is one such patient who underwent an open necrosectomy and a diversion ileostomy because he had a colonic communication and a feeding jejunostomy. So this one surgical procedure takes care of diversion of the colonic communication, necrosectomy, the enteral feeding purpose, and a close continuous lavage to irrigate this as long as it is necessary. And also we have salvaged some of these patients. As I told you, you put in this newer self-expandable metallic stents or the lumen opposing stents. Sometimes they get into this peritoneal cavity. You can see this is one such stent which is migrated into the peritoneal cavity, and you take out this stent and then do a thorough debridement, close this defect, and then do a close continuous lavage. So we have this outcomes of different open techniques. You can see this, the close continuous lavage system. People think it is associated with increased morbidity and mortality, but you can see that the mortality associated with these procedures is less than 10% in majority of these series, and the morbidity is also very, very low. And you can see this, the complications that are associated with this are also significantly less, not what is publicized. Now, simultaneously with the development of open surgery, we have also evolved laparoscopic or minimally invasive techniques. Surgeons across the globe, surgeons within India, and I'm sure a lot of surgeons like Sopimat and other surgeons have been doing this minimally invasive laparoscopic interventions for walled-off pancreatic necrosis. And there has been a paradigm shift from laparotomy to minimally invasive laparoscopic techniques, especially if you are intervening first naive cases, you select them and intervene laparoscopically, they do very well. Tertiary care centers with sufficient expertise are increasingly switched to these minimally invasive techniques, be it endoscopic or laparoscopic, and they have shown to be associated with lower morbidity and mortality. So when we are doing laparoscopy, this can be done primarily, it is very, very difficult to do a laparoscopic intervention after an endoscopic intervention or an interventional radiology procedure intervention, because it is very difficult to localize these collections laparoscopically. So post endoscopic interventions or laparoscopic interventions radiological interventions, these patients require open surgical. But if you are taking these patients primarily for surgery before any intervention, laparoscopy is a good indication. It can be done transgastric, retrogastric, retrocolic, retroperitoneal scopic debridements can be done. All potential areas of collections can be accessed. Complete removal of sequestrum is possible, and it is always augmented. Suppose if you are not able to complete the procedure, you can always use a hand port. Just to show you how to see, this is what the endoscopists do. We put in a stent, but here we create a wide stroma here. It's almost 5 to 7 centimeters we create here, either by stapled or a sutured anastomosis. The biggest advantage of this is because of the natural peristalsis, this defect, this anastomosis that we create closes whenever the person takes food, vis-a-vis what happens with the stent. Because the stent keeps it open, it is likely that some of the gastric contents can go into the retroperitoneal cavity. And walled-off pancreatic necrosis, you can see this various data, laparoscopic data, which shows significantly good results with very low morbidity and mortality from different centers from across the globe. Now, retroperitoneal scopy is another approach that can be done. This is especially done like these patients who underwent initial interventional radiology procedure in Panther Trial here. Now, this necrosis is approached by a direct retroperitoneal scope after dilating the PCD tract or by using a trocar directly. This can be done in critically ill patients, and there is no peritoneal contamination in this patient. Just to show you one example of this patient, this lesion was marked out by an ultrasound here. Wall necrosis that was almost pointing onto the flank here. Now using an OptiView trocar, actually most of the bariatric surgeons who are seeing this are very well used to this OptiView trocar. This is how they gain access into the peritoneal cavity under vision. So here we are using the same technology to gain access into the walled off pancreatic necrosis. You can see this is how it gets in. Once this is in, you let out all this fluid from the trocar, and once this is done, we can use the standard laparoscope to get into this, visualize this, and we can have an additional port that is inserted. Most of the surgeons are used to this single port laparoscopy right now, in the sense they are used to closed port now. One port beside the port as compared to conventional laparoscopy. We are all used to this, so that we can place one additional trocar or two additional trocars parallel to this initial visualizing laparoscope, and because of this, using this blunt instrument, you can do a very effective debridement. You can see this huge tortuous vessels that traverse across the retroperitoneum do this, and we can be very careful using this blunt instrument. It is possible that we can do very good necrosectomy. You can see this, we are going across the vessels here, trying to avoid these major vessels, and you can do this complete necrosectomy. Once you have done with this, then you can irrigate this entire cavity, and then we can put a drain and come out. This is one such patient who has had two drains into this. We can irrigate this, and subsequently the patients do very well. The biggest advantage is, especially for gallstone pancreatitis, suppose this patient we require, suppose you have to do a lap chole at the same time, we may not be able to do this, but all other pancreatitis we should be able to do it. And there is huge data to show that this retroperitoneal approach is a very good approach for selected patients, and this can be very effectively undergo this debridement. So centers which are doing this advanced procedure, this is one such hybrid procedure that we do in some select patients, like this walled off pancreatic necrosis with lot of debris, not small amount of debris, but lot of debris in this patient. Now we put this trocar directly under endoscopic guidance into the walled off pancreatic necrosis. You let off all this fluid. Now this is the biggest advantage. You have a big trocar that goes directly into the thing. Then you can use this standard cannulas to suck out. Now once the fluid is let out, we can withdraw this trocar slightly into the stomach. This is how we can withdraw this trocar, and subsequently use a stapler to create a wide anastomosis here. And once you have done, you can use an endoscopic approach or a laparoscopic approach to do this debridement, and subsequently you can close this small defect that we make on the anterior wall of the stomach. So if you compare all these minimally invasive techniques that are available in the world today, you can see this: the percutaneous drainage, the endotherapy, laparoscopy, or retroperitoneous approach, all of them seem to have equal, almost equal results, as long as you are choosing these patients very, very carefully. The complications associated are almost the same. So the issues regarding minimally invasive techniques, now the data supporting minimally invasive techniques is very, very limited. The lack of well-designed trials, lack of widespread expertise, variations in techniques in different institutions, and sample size to show significant outcome is very huge, and we do not have such huge volumes to show. Extension to routine clinical practice has lots of limitations of these endoscopic technologies. So we can see this, we have these wands, as I told you, walled off pancreatic necrosis. These can extend into the mediastinum, paracolic areas, mesentery, and the pelvis. And if you see the preferential techniques, we have these depending on this walled off pancreatic necrosis, where they are present, we can either do a percutaneous drainage or an endoscopic drainage or a interventional radiology or a retroperitoneal scopy. But surprisingly, these are the preferential techniques, there seems to be less of compliance to this. There is poor compliance to this, basically because the lack of endoscopic or laparoscopic expertise in these things. There is poor compliance to these procedures. It is done in tertiary referral centers which could have expertise, but it cannot be extrapolated. Though we have these guidelines, it cannot be extrapolated to every single individual, especially to some of these peripheral centers where they practice. So, is open necrosectomy obsolete, or is it still useful in 2020? This is the question that is repeatedly posed, and all of them who keep seeing this, attend these workshops or keep seeing these videos, they feel that as on today it is only interventional radiology or endoscopic drainage or laparoscopic drainage, and most of the people believe that open necrosectomy has no role. Please, that is not the thing. I'll show you some of the data. This is the beautiful data that comes from Gangaram hospitals from our own country, wherein they reviewed almost about more than 2,255 patients. And if you see the peripancreatic wall of necrosis, these patients who come for surgery, you can see this, a predominantly very high number seems to be still going for open necrosectomy even in even in 2020s. This is a beautiful article that comes from our own country. Now, this is a beautiful article again that is published from huge centers which have high volume and centers which are doing both endoscopic, laparoscopic and open surgical approach. Mind you, if you see these authors, some of these authors were authors of the Interventional Radiology or the Panther Trial, some of the big names in endoscopic drainage, Todd Barron, you talk about all these people, and we have surgical groups or laparoscopic surgeons who have been involved in this. So, this is a huge pooled analysis of multiple centers that came in from across the globe, and the practice patterns that happened, 51 hospitals from 8 countries. We had about total about 1980 patients, and if you can see this, majority of them seem to have undergone open necrosectomy. Laparoscopic approach follows by endoscopic approach. So, if you can see this, though data, because whatever you're doing you publish, but the ground reality is still majority of these patients are going for open necrosectomy basically because they are not amenable for these procedures or expertise is not available in this. And even if you see one of a beautiful publication from one of the district hospitals from India which shows that open necrosectomy is still the way to manage these patients, especially in peripheral centers. And this is a beautiful data which shows again. So, with the advent of minimally invasive technique, there has been an initial shift from open to interventional radiology to endoscopic procedures, but with more and more data coming in and with more and more data, there seems to be some shift towards laparoscopy and open surgical approach, basically because of the limitations that we have on the endoscopic side or the interventional radiology procedure. Now, let us see the data that is published actually comparing endoscopy and versus surgery. Now, this is the data that most of the endoscopists keep quoting. Now, this is compared with endoscopic with surgical step-up approach. Now, all patients had only transgastric access. Now, transgastric single-step surgery would have yielded a superior approach. So, this is compared all modalities. Suppose if this data is included only surgical transgastric approach, I am sure this data would have been better. This is another study which compares open transgastric debridement and internal drainage of symptomatic non-infected vault of pancreatic necrosis. The success and mortality are similar, and this is one such paper which has compared different types of techniques. Surgical necrosectomy for necrotizing pancreatitis, this has included laparoscopic approach and open surgical transgastric cystogastrostomy, debridement, cystojejunostomy and debridement. You can see this. This is a beautiful article which is published and which shows that surgical transgastric necrosectomy is an excellent one-stage option for symptomatic walled up pancreatic necrosis in a highly selected group like what is done in endoscopy. Now, this is the publication that comes in endoscopic versus laparoscopic drainage of pseudocysts and walled up necrosis from our own country, and this shows that endoscopic and laparoscopic techniques have similar efficacy for internal drainage of suitable peripancreatic fluid collections less than 30% debris. So the cutoff seems to be 30% debris. This is usually predicted by the cross-sectional imaging or by endoscopic ultrasound. So whenever we have less than 30% debris, it has been shown that endoscopy and laparoscopy are similar or surgery is similar, but if you have more than 30% debris, I think these patients do well with laparoscopic interventions or surgical interventions. So this is a meta-analysis of endoscopic versus surgical treatment for infected necrosing pancreatitis, and you can see this given heterogeneous procedures in the surgical group as well as low amount of randomized evidence. Further studies are needed to evaluate the combination of different approaches and appropriate time points of interventions. So what do we do initially? What happened was initially when the Panther trial started, we started referring all our patients to the interventional radiology. Subsequently, the endoscopy came in a big way and we started draining all these patients endoscopically. But subsequently, because we known that there are a lot of limitations of switching or limiting ourselves to these single interventions. Subsequently, we started having this pancreas board which decides which type of intervention this patient has to undergo. If you see our own data, when Panther trial came in, our surgical interventions become very, very low per year. But with advancement of this, with better understanding of the various pathophysiological processes that have been happening, we see that there is increasing number of things that have been happening on the surgical side. If you see this increasing number of necrosectomies being done, initially we had endoscopic ultrasound which is evolving, but as endoscopic ultrasound stabilized, the morbidity mortality is less, but you can see the surgical interventions have tremendously increased. And if you see our own data from our side, you can see this, whenever we do primary surgery in these patients, the mortality is very less. Post PCD drainage, the mortality is slightly higher, and post endoscopic ultrasound, the mortality is very high. So you can see this, primarily if these patients come for surgery, the mortality is very low and it can be compared with any other intervention that we have as of today, and the overall mortality is about 14%, which is very, very acceptable. So to conclude this session of walled-off pancreatic necrosis, we all know that all the management concepts of walled-off pancreatic necrosis have evolved and standardized from conventional surgical principles. There is no doubt about this. Surgery continues to be the standard of care because of several limitations of minimally invasive techniques and because of compliance issues across the globe. Primary surgery including laparoscopy and retroperitoneal scope are associated with good outcomes and low morbidity and mortality, as I have shown you. Interventional radiology and endoscopic failures require open surgery. As I told you very clearly, naive cases, if you are taking primary, they are very good for minimally invasive, but if they are interventional radiology or endoscopic failures, it is very difficult to localize this necrosum laparoscopically. So these cases require open surgical intervention. IR and endoscopic failures are associated with increased morbidity and mortality because of the septic and nutritional factors. By the time they come for surgical intervention, they are nutritionally depleted and they have a lot of these septic complications. So obviously the morbidity, mortality associated following interventional radiology and endoscopy failures is very, very high. Surgeries complements interventional radiology and endotherapy. So I'll read with you this beautiful article that was published in 2017 of different type of intervention. It says many different interventions in varying states of evolution are available for treatment of pancreatic and peripancreatic necrosis. These interventions should be offered in the context of optimal intensive care and medical management, and that a multidisciplinary approach is required in a center with specialized expertise. Obviously, this is very, very clear, and you can see this. What we do in our center, I'll show you. We have a walled-off pancreatic necrosis. It is in good approximation to the stomach of duodenum, and it is less than 30% debris. These are the patients who go for endoscopic intervention. If there are more than 30% debris, these patients require an open or laparoscopic approach. Now, patients who have walled-off pancreatic necrosis beyond stomach and duodenum, less than 30% debris, again you can do a radiological procedure or an open and laparoscopic procedure. If it is more than 30% debris, sick and unstable patients, we do a radiological step-up approach followed by, if failed, we do open surgery. Stable patient, we do radiological step-up approach followed by open surgery. Stable patient, we can do a laparoscopic or open approach. This is a beautiful article which is published from an endoscopist, Sham from US. He is a proponent of endoscopic ultrasound and US drainages. Now this is a beautiful article which comes from which endoscopic, which says all those walled-off necrosis which are absolutely localized. You can see this is the center. These are the patients who do very well with endoscopic drainage. Now all those necrosum, walled-off necrosis or extended walled-off necrosis beyond stomach or duodenum, extending into the paracolic area, mediastinum and pelvis, these are the patients which require surgical intervention as far as possible. If the patient is unstable, you can require an endoscopic interventional radiology procedure followed by surgery. So one type of intervention does not fit at all. As in today, it's a multi-modality treatment approach which requires an HPB surgeon, an endoscopist, an interventional radiologist, and they're tailored to the anatomic location, comorbidities and available expertise. In addition, there is a big role for critical care intensivists because these are the patients which are best managed in critical care during the initial phase, and subsequently we come into the picture and decide that group of patients which require intervention. So it is absolutely together we stand, divided we fall. It is basically a multidisciplinary approach of complicated walled-off pancreatic necrosis. It is no more interventional radiology or endoscopy or surgery separately. We have to evaluate these patients as in today. And before I conclude, I'll just show you this cartoon which I made for my department some time back. I only hope some sort of this thing that comes with more and more robotic surgery, flexible systems that are coming in like this. I hope a robo can be created like this which can go suck out this entire content and then subsequently put a zipper like this. We used to do this open zipper laparoscopy in some of these patients with extensive peritoneal contamination. I only hope that we can do some sort of an intervention like this. We can close the zip and then open the zip whenever we want and do a necrosectomy again. Thank you once again for the patient hearing. I'm sure I've shared my views what is happening in our department. I'm sure this is what is happening across most of the centers, but I would like to listen to what is happening from senior surgeons, my colleague surgeons, and also the juniors who are viewing this webinar live from AIG Hospital. Thank you so much once again for the patient hearing.
I would like Dr. Swapnil Math and Dr. B.R. Patil to comment about their findings.
Well, this is an excellent talk. Of course, it was expected from GV. And he has talked so clearly and so lucidly that I think he has left no doubts unanswered. And what I would like to say is his last few slides had excellent take-home message. And he has given beautifully all tips that have to be taken. And one of the best slides, what he said is that we need to take the many factors into consideration before deciding, like the size of that, whatever walled-off necrosis is there, its relation, and what is the content, and what is the condition of the patient, and what facilities do you have, what expertise do you have, and also the patient factors. I think they all are going to influence the management decision. And I do feel that whenever the people have studied the endoscopic versus surgery and all, there must be an element of bias in many of the studies when they decide, unless they sit together like as they do in AIG and decide what should be done in which patient. And I'm sure there will be some certain amount of bias, and that probably influences the results also to some extent. One question I would like to ask him at the end of it: what size catheter they put in? Of course, And the step-up approach is, of course, now becoming popular at many places, especially in sick patients, because it helps in control of sepsis and it helps in improvising the nutrition, and possibly patient would do better. And off late we have started doing this. And what he mentioned is very right, that any intervention after these interventions, that surgical intervention becomes more difficult because the cyst collapses, the space collapses. When you go and you find it difficult to enter into the right plane, a lot of edematous planes will be there. So the surgery, whether it's laparoscopic or open surgical procedure, it becomes little difficult to get into the right plane and also into the right content, the plane. So that's what makes it a little more difficult after repeated interventions. This is just my observation. And I just want to ask another thing is, are there any published series about the hybrid technique what he showed that appears to be quite interesting? Or is it just that it is in the beginning phase, it's just the AI's innovation? Because I have not read any references about that kind of technique, and it is the first time I am hearing that.
Yeah.
So these are all what I would like to hear from GV.
Yeah.
Size of the catheter and the hybrid technique and the things.
No,
yeah, please.
basically, very right actually. Now everybody has been talking about this minimally invasive techniques actually, because we had this combined expertise both on the endoscopy side and laparoscopy side. We have a very small series of these patients actually. I think we have about 9 patients so far whom we have done this way. It's a very small series, but this is again done for very select group of patients. It cannot be done for any this thing. But we are going to soon publish this because we just have about 9 patients so far whom we have done this. And once we have a significant number, then I thought we'd publish this. This is one of the videos that I've been sharing with my surgical colleagues. Actually, it's a beautiful technique, actually, especially if you have more necrosum, and if you feel endoscopically it is difficult, when you can do this percutaneous approach, and then you can do a wide anastomosis, and then that enables us to do either you can go endoscopically or debride, or you can do put in the same instrument and debride actually. That's the biggest advantage of this.
And I would like you to mention about the size of the catheter, because many of the times what we get the references from other places are all that a very small size catheter will be put in that, which may not be able to drain it adequately. And many times they come with a blocked catheter with septic complications and all that. And also, how do you monitor them? Because many times sometimes one would forget that they have done the job, but also it needs monitoring where the catheter is blocked, what is happening inside, and whether it leaks around, where the peritubal leak is there. So how do you, what size catheter do you put, and what is the protocol in following it up? What tips you would like to give?
See, what happens is actually our interventional radiologists, suppose they're putting in actually, they usually put in a 12 French catheter initially, drainage catheter, pigtail catheter initially. So what they do is, after they put in the thing, they see how much of fluid has come out. Now repeatedly, actually the other thing that happens is people believe that we just leave the catheter to drain by itself, but surprisingly what happens is this necrosum, especially the small amount of debris, tends to block the holes on the pigtail catheter, and some of these patients continue to have fevers, and this we attribute it to the pancreatitis. So basically it is because this fluid is not being adequately drained. Now these are the patients who require, so after you put the initial catheter, once it is matured after about weekdays time, either you can dilate this tract and then put in bigger catheters, or you keep flushing this so that the catheter doesn't block. But these patients have to be periodically followed by routine screening ultrasounds to make sure that there is no fluid that is accumulating, and we keep irrigating these cavities. So once the tract matures, because there is again lot of limitation on the radiological expertise that is available, some people are scared to dilate this tract especially, but majority of these things can be sequentially dilated. And you can see this actually when in a retroperitoneal scope, we are putting in this almost a 12 millimeter trocar, we are putting in very easily. The same thing can be done on the initial radiological approach, but surprisingly they usually put only a 12 French catheter, which is subsequently dilated. But in my department right now, if the wall of necrosis is accessible like this for a radiologist, actually I will not send this patient for radiological intervention. I'll directly put a trocar and then evacuate as much as possible.
Yeah. And which are the other cases where you will decide that, okay, fine, let me go in, apart from what you have mentioned already in your talk? like say there is paracolic extensions and other things and those things. Okay, this is a patient I need to go in. Let me not try anything else.
Yeah.
When is that you?
This is a very difficult question that you pose, Sophie. Actually, what happens is, post endoscopic intervention or post radiological intervention, if the patient is deteriorating, we take this patient for surgery. There is no doubt about this. Actually, we tell them, okay, we stop this endoscopic approach or interventional radiology procedure. It is time that we switch things before the patient is absolutely totally malnourished, and then we have to use real higher antibiotics for this patient. The other thing is, actually, whenever we have significant debris in this patient and it is extending, we clearly tell them that these patients have to go for surgical intervention. The patient is stable, and we have good, I mean, actually, I've seen Sopimat's place. Actually, I've seen many other centers. We have beautiful the intensive care unit wherein you can monitor this patient very well, and the anesthetists are very well trained to tackle with this thing. I don't think we should have any problem tackling with this patient.
Would anything additional doubts like would cause you to say alter your decision to go in, like say maybe possibly you suspect that there is something else is happening, maybe that vascular complications or like setting in other things and
no, especially if the patient has any associated bleed, associated perforation. These are the patients, as I told you, there is no doubt about this. Actually, suppose the patient has got an enteric communication, this patient have to be done surgically. There is no two thoughts about it. You do a cologram, if it is going, patient is sinking all of a sudden and the patient has got some watery diarrhea, or you see some fluid coming out of the rectum. These are the patients, there is no doubt about it that we have to take them for surgery primarily without any, there is no more endoscopic or radiological intervention in this patient.
So this makes it very important that surgeon needs to be involved from right from the beginning,
Yes.
even if the endoscopist does the intervention or radiologist does. Yeah.
See,
And also he needs to monitor.
I know actually one such patient who was managed, who actually this patient had diarrhea persistently. They thought it is antibiotic induced diarrhea. Surprisingly, this patient had a colonic communication. They thought it's antibiotic induced diarrhea, and they continue to treat this patient. These patients come back absolutely very, very sick actually. So these patients require some sort of a diversion initially, necrosectomy, diversion, and I mean, you can salvage this, many of these patients if they intervene at the right time.
And also sometimes the patient might have associated gangrenous cholecystitis sometimes, in some cases, and
Very
maybe
right.
bowel necrosis.
Yes, absolutely. Because of vascular complications, we'll have to go in and then check this.
I would request my other colleagues if they have any doubts or questions coming up or any thing they would like to. I think another important, you have made a very, very interesting contribution. That's the nutrition. I think this is one of the neglected aspect when we manage these patients. I think that's very, very important that we need to give a lot of importance to the nutrition, especially when the treatment is delayed, when the patient stays for longer time in the hospital. I think we have to literally take all precautions so that the albumin doesn't fall and the nutrition is well maintained and all that. Thanks, GV, for the nice talk. I would request my other colleagues to come in.
I think there is a question from Dr. Nagaraj Sanu. On the YouTube, there is a question from Dr. Nagaraj Sanu.
The same as functional necrosectomy.
Yeah.
The question is the necrosectomy same? What is actually as a functional necrosectomy?
Sorry, Dr. Patil.
What exactly is a functional necrosectomy?
Functional necrosectomy?
What I see. The point I really didn't get this as well. But the question asked was, what exactly is a functional necrosectomy?
So the idea of doing a necrosectomy is to remove as much of infected necrosome as possible. So basically, so there is a, I mean, there is a myth among the endoscopists. Actually, they're saying that actually if you just drain the peripancreatic fluid collection, it is sufficient. But necrosectomy is required because there is the necrosome itself is associated with a lot of infection, and that is the source of the fluid that forms subsequently. So if you ask me, functional as much of necrosome has to be removed. Any of the procedure, the complete necrosome has to be removed by any of the procedure, either interventional radiology or surgery or endoscopy. Unless and until you remove the entire thing, it doesn't improve the overall condition of the patient.
Now, another question, GV, you told us that there are a lot of debris and necrosis and which are missed when you do a CT. And you showed us a lot of images on an endoscopic ultrasound that show that there are a lot of necrosum that is missed when you do a CT. But do you depend on a CT scan to decide whether this patient goes on to a necrosectomy, or is it on endoscopic ultrasound that makes a decision?
Very good question. The first cross-section, the basic cross-sectional imaging is a good contrast enhanced CT. This is the basic. Now, if the CT scan shows localized collection in relation to the stomach or duodenum, then these patients undergo an endoscopic ultrasound. But if the CT is showing extensive necrosis and extending beyond the stomach or duodenum with extensive necrosum, I don't think there is any role for endoscopic ultrasound unless and until there are centers which practice an endoscopic drainage and a percutaneous drainage, as I showed you in some of these patients. So the basic cross-section, the basic investigation on which the entire management rests is a good CT scan. CT is a must. Endoscopic ultrasound is not the primary investigation. CT is the primary investigation, followed by endoscopic ultrasound in select few patients which have got good approximation to the stomach or duodenum.
When you do an endoscopic drainage, and how long do you wait and decide that I have to go in? When you say that the endoscopic ultrasound hasn't worked, is it only clinical, or you do a repeat CT, or how do you go about it?
Very good question. Again, as I told you, actually our own data I showed you, actually whenever we putting this endoscopic drainage, now you follow up this with conventional ultrasound. I told you majority of these patients just putting in a stent, you get relief. Now, if there is any persistent collection, that is, if the patient continues to deteriorate, shows signs of deterioration or no improvement, then we go in endoscope to check the patency of the stent. If there is any debris that is blocking, then we remove the thing. Or if the patient continues to have same fever, then we do a nasocystic drain. So it's a periodical image, both endoscopic and ultrasound image that is done, not an endoscopic ultrasound. It is basically an endoscopic evaluation and an ultrasound imaging that is done in this select group of patients. And certainly if there is no necrosum that is seen in relation to the stomach or duodenum, then certainly we go do a cross-sectional CT scan again.
When do you decide in a patient who say bleeds, or you have bleeding PR or the hemoglobin drops, when do you decide that you have to go in, or do you have interventional radiology put in a file, or do a coagulation?
This again is a very good question. Actually, if the patient has got significant drop in hemoglobin, and we think it is basically because of some sort of bleed inside, the first procedure that we would certainly like to do is an interventional radiology procedure to see if this patient can be stabilized, because obviously these patients are critically ill. These patients, we try to see if an interventional radiology procedure can be done to embolize this. But again, a significant number of times actually we are not able to localize these vessels, especially the retroperitoneal vessels. It is very, very difficult to go in and embolize these things. And we know that a couple of patients, actually all of us will know that actually we go in, debride this, and suppose we are not able to secure bleed. As I told you, the second method what we practice, it's called the packing method. We pack the entire retroperitoneum, the wall of collection actually, and then subsequently 48 hours later we remove this pack, and these patients do, some of these patients do very well.
Do you have to reopen them, or you just pack it and tag it with a rice tube so that you can do it? Or you just pack it and close?
No, these are the patients who require an open laparoscopy. We usually don't close the thing, we just put interrupted sutures and then go in for a relook laparotomy, and then go in, remove the pack, visualize the entire thing, because there is no way we can just remove the thing and just let it go, and then we have to visualize the thing and then do the procedure.
It is done 48 hours after the first
Yes, after the 48 hours we reassess the thing and then do the thing.
So the 48 hours is the time that you require to stabilize the patient and get him out.
Stabilize the patient, and then by the time we expect, because of the tamponade effect and basically because of the pressure effect, most of these vessels can seal off, and then we should, and also the cyst collapses, the approximation, all these help in stopping the bleed.
we talked about nutrition. What would you suggest for the youngsters to use as the best modality of nutrition for these patients who are sick? Do you go in for peripheral nutrition, or do you suggest that they go in for a nasal tube, or how do you go?
Now, all these patients whom we are managing in the first 4 to 6 weeks of acute pancreatitis, it is better that you manage. Suppose if they are not tolerating oral, I think best would be to put a nasojejunal tube. This is the best way to tackle these patients. And even these patients who are undergoing endoscopic intervention or radiological intervention, suppose they are not tolerating orally, it is best to put in a nasojejunal tube. And if you are doing an open necrosectomy, I think it is mandatory that you do a feeding jejunostomy along with the thing, so that these patients can be, especially suppose you have some sort of unless or until, even I have shown you a patient who had a diversion ileostomy, then we do a feeding jejunostomy, because the best way to manage this, it is very, very difficult to manage with parenteral nutrition because of the complications and because of the limitations that we have. So I personally believe all the youngsters, you put this patient on enteral nutrition, oral if not tolerating, nasojejunal is a very good way to treat this patient, and most of them do very well. And as they start tolerating oral liquids, you can slowly switch over from nasojejunal to oral feeds.
Is there any particular formulation for these nasojejunal feed?
Yeah, it's a very good question. Actually, this basically we have. I mean, if you have a dietitian with you or a nutrition department with you, they calculate the amount of the umpteen number of formulations available. If these formulations are not available, actually the best thing would be to take whatever is the local thing, whatever is home cooked. Actually, these can be put in the grinder, mixed, sieved, and these can be pushed through the nasojejunal tube. I mean, basically, we should have a good nutritionist who can tell us based on the requirement. They can calculate the thing and tell us, and then we start feeding these patients through the nasojejunal tube. There are umpteen number of formulations available in the market for basically, because I don't want to contradict any industry. Yeah, there are umpteen number of formulations that are available, which are pre-prepared and which can be tagged on. But again, these are very expensive. I mean, very small percentage of patients can afford this.
The reason why I asked you, it's not that. The reason why I asked you is, what was the panchamrita that we use? What I use is whatever we use, and I put it in a mixie, make it in a thin stream.
Absolutely.
Then we inject it through a nasojejunal tube.
Absolutely. I think whatever is homemade, actually, you can just put them.
It is as good or even possibly better than what you get.
Yes, what is commercially available. Yes.
That's what. Wonderful. I really enjoyed with GV.
Thank you so much. Thank you so much.
We have two questions from Bekodi and Dr. Deepak Patil.
Deepak, your experience with the bleeding in the cavity after any intervention. Actually, this was another question, Dr. GV. I saw that you put a retroperitoneal drain for a necrosectomy, in the left flank, and went between the spleen and the colon, and then I could see a large vessel that was going on the interior part of your video. I mean, the video you showed, the pulsating vessels that you showed. What happens if you injure it, and how would you tackle such a situation?
So these are actually these patients, whomever we are doing these procedures, retroperitoneal scope procedure that you're talking about, these have got good cross-sectional imaging, and we have an ultrasound. Actually, it is done under ultrasound. Even on table when we make sure that every single puncture goes under ultrasound guidance. It is not a blind procedure, please. It is not a blind procedure. We cannot go, because what happens is, the moment you deflate, I mean, the moment the fluid comes out, very rightly said, it becomes very difficult to put in the second trocar parallel to that actually. So either what we do after we completely do the fluid extraction, we fill this with saline again and put in this second trocar to make sure that you are in the right place. And it is always that we have the radiologists with us to guide us to put this trocars.
If it bleeds, would you be able to tackle it under the guidance, or would you do a interventional radiology?
Yeah, basically because we are doing it as long as we feel that it can be managed with any of the equipment that we have. Suppose any of those vessels that I've shown you, maybe if you have this capability to put those, now we are very fortunate that we have all these Liga clips that are available. Actually, the good clips that are available in laparoscopic practice, they can be used very effectively to close these things and then can be tackled. Suppose if you are not able to tackle this, I mean, you can always open up, because we always know that we made the incision, we can just make the incision directly, go in, and then we can pack the wound and then subsequently do the debridement.
And another question, G, was one absolute or absolute indications for open.
One absolute indication for surgery. If I don't have the endo,
because we are all general surgeons. We would like to say yes, I am going to operate in this case.
If I don't have the endoscopist with me, if I don't have the radiologist with me,
so you are talking about if you don't have a board with me, I am going to operate.
So actually, if you ask me, actually though I do endoscopic practice, but I strongly believe that surgery still has a big role in current day clinical practice.
Yes.
Irrespective of whatever said and done. So that just because the radiologists are publishing more, just because the endoscopists are publishing more, and just because the surgeons are not publishing the data, it doesn't mean surgery doesn't happen.
They are busy operating.
If you ask me, actually, I mean, I think I'll still, a good patient with a good functional status, I think so primary surgery would be a good option even in 2020. I mean, if you have the other expertise, yes, definitely it causes decreased mobility, but if you have a good functional status and you don't have this expertise, I think we should go in for surgery.
Because all the data you showed, you know, everything, it was a delayed open surgery which are the least mortal.
Yes.
So I think, as you put it, you know, it is a delay and defer and debride and
absolutely. Yeah.
Those three. And we are very lucky to have a good board with you, so that you know, you can take a very nice decision, so that you intervene when necessary and you know, get away with minimal access when possible. So I should congratulate you on that. Wonderfully put and really enjoyed it.
I know SOPI does a lot of minimal invasive procedure. Actually, SOPI does a lot of laparoscopy work. I've seen him doing it.
Both as well.
A lot of people do it actually. A lot of people do it.
Lucky.
He's a team by himself, you know. He's a team by himself.
Yeah. GV, I just had one doubt, and I just wanted your clear thoughts on this. When do you suspect that possibly this patient has got a disrupted duct syndrome, and how would you deal with it? What would you do for this kind of patients?
The compartment syndrome?
Disrupted duct syndrome.
Like, this is a very good question actually. See, whenever we did this open necrosectomy, we never bothered about this. We know that invariably this patient will have a disrupted duct. Absolutely, there is no doubt about this actually.
Yeah.
So, whenever we did a surgical necrosectomy, we always anastomose this to the stomach. So, even if the patient had a disconnect duct, it leaked into the stomach. So, we never had this problem. So, but the only problem came in when we started putting these drains outside. Now, these are the patients who come with this, this thing actually. Now, these again are the patients actually, now whenever we have this patient with disconnect duct syndrome and we have done open surgery, and we have this persistent drain that is coming out from the thing. Now, these are patients which are difficult to manage. I fully will agree, majority of these patients do very well. Over the period of time, they settle down. Now, patients who do not settle down and who have increasing amount of fluid that comes out. Now, usually what happens is, majority of them, actually the duct gets disrupted somewhere at the head body junction or in the distal body. Majority of the time, the fluid comes down spontaneously. And these patients do very well. Suppose if it doesn't come down, we wait for adequate time for the fistulous tract to develop. Now subsequently, now there are two ways to do this. If you think you are a good open surgeon and then you can go in and do, suppose you do a good MRCP and then you show that the entire duct is disconnected, then you can do either a fistulojejunectomy or you can do a pancreaticojejunostomy if you are very competent enough. But majority of the surgeons are defying this procedure. So now what the endoscopist started doing it was, they started clamping this drain and they let this fluid accumulate, And when this accumulates to a certain amount, about 60-70 ml, they'll go in with an endoscopic ultrasound and put in a stent into the cavity and drains into the stomach. This is a good modality that I found, that initially we used to go in, we have done a good series of fistulojejunectomies and open surgeries, but now with the advent of endoscopic ultrasound, I found this a very good modality right now. You clamp the tube, wait for some time for this fluid to accumulate in that area, go in with an endoscopic ultrasound, put in a stent so that it drains into the stomach. So this is a good way to tackle these patients who have this disconnect duct syndrome, to treat them endoscopically in current day endoscopic practice.
I learned this something good from you.
Nice
Thank
idea.
you.
Very good idea. Actually.
Sir, GV sir, I am receiving a lot of feedbacks from the other members of the surgical faculty. Apart from Hubli Dharwad city chapter, the Belgaum people have watched this, the Kolhapur, the Pune, Bellary, and some parts of Tamil Nadu. They were really very much happy to listen to you, and they have sent their compliments. All of them have sent their compliments to you. One thing, if the postgraduates would have logged in earlier, and what sir told in his initial slide or initial talk about the mnemonic of pancreatitis.
Yeah.
See, if all postgraduates, if you have understood this mnemonics of pancreatitis, you can go back and read tonight of each and every word what sir has explained, covers the whole of pancreatitis and its management and its investigation. I think Dr. Mulki Patil is there.
Yes, sir.
Dr. Mulki Patil. Sir,
Yes.
Thank you once again, GV sir, for giving an excellent talk. From greetings from Hubli Dharwad city chapter. And we thank you immensely from our heart. We felt that you were in Hubli with us today. And I request our secretary, Dr. Mulki Patil, who is also very active in COVID activities and is in the COVID warrior, to propose the vote of thanks.
Good evening, sir. Myself, Dr. Mulki Patil, Secretary SI Hubli. Today we had an excellent talk on walled off pancreatic necrosis, various procedure by Dr. G.V. Rao sir. On the behalf of senior faculty members and on the behalf of ASI Hubli Dharwad, I extend my heartily thanks for accepting and giving this talk today. Thank you very much, sir, on the behalf of ASI Hubli Dharwad.
Thank you
Thanks,
so much
Jay.
once again. My
Thanks a lot.
humble thing, actually, I'm really humbled by this invitation, and very nice to
thank
see
you.
all my friends actually. Thank you so much. Stay safe. I think I just hope that we all get over this COVID crisis and meet again in person
Physically.
very soon.
Physically. And enjoy the Hubli hospitality.
I would like to extend my thanks to our President ASI, senior faculty member, none other than Dr. Sopimat sir, who is always guiding us in various activity and today also being a chairperson. Thank you, sir, Sopimat sir.
My pleasure.
And also extend my sincere thanks to Dr. B.R. Patil sir, senior surgeon of Hubli Dharwad.
Thank you.
And also Dr. Srinivas Pai sir, Professor and HOD of
Thank
Department
you.
of Surgery.
I've been listening and no comments because it's so very clear, the topic.
Yes,
Thank you.
Yeah.
thank you,
Most
sir.
of the decision making is
And
made
last
by
but not
PR.
least,
Thank you.
We should
Yes.
also thank
Yeah.
Mr. Satya, who led the technical team, and such a good relay and video everybody could experience it. Thank you, Satya.
and also thanks to my president, who is taken my charge in arranging, organizing, and reducing my responsibility in this COVID activity, none other than Dr. Vijay Kamal sir. And thank you very much. And once again, all the participants, those who are joined a little late because of some of our residents are in the hospital and duty. Thank you once again for all. Thank you, sir, on the behalf of ASI.
Thank you so much once
Thanks
again.
to
Thank you,
everyone.
sir. Thank you
Thanks
so
to
much.
GV. Thanks to AIG. Thank you. Thanks all.
Thank you. Thank you. Good night. Good night,
Good night, sir.
everybody.
Good night,
Good
sir.
night.